Picture a normal evening with your family. Without warning, your loved one collapses to the floor. For many, the horror of witnessing a sudden cardiac arrest is all too real. Life-saving medical resources are seemingly never close enough. But what if the power to buy your loved one precious time was closer than you ever imagined?
ECMO 3, activate to Southville for a 45-year-old male ECMO candidate. EMS is 15 minutes out, STAC 4 will be your talk channel.
Copy of responding Southville, STAC 4. Show me around.
Copy, I'll show you around at 12:41.
In 2015, at the University of Minnesota, started doing an initiation of bringing cardiac arrest patients back to the cath lab. Otherwise, we found that there was just nothing further to do for a ventricular tachycardia or fibrillation patient. They were being called either in the ED or on scene as time of death. So Dr. Yiannopoulos started in 2015 bringing these patients back to the cardiac cath lab, where they underwent the procedure to fix a cardiac lesion. And instead of just fixing the lesion while they're in arrest, he elected to put them on ECMO, which is the cardiac life support device, and then go back in and fix the lesion at that point in time.
Chef 911 had the opportunity to travel to Breckenridge, Colorado, with a few members of the University of Minnesota's Mobile Resuscitation Consortium. As everyone hailed from different parts of the country, Colorado was an opportunity to learn about ECMO while still engaging in fun activities like skiing and snowboarding. But Chef 911 wanted to add a fun twist. Cooking together is a powerful way to build relationships and deepen connections with others. It creates a shared experience, encourages communication, teamwork, and a sense of accomplishment. As people collaborate in the kitchen, they naturally engage in conversation, share stories, and learn about each other's preferences and backgrounds. The team aims to use cooking to help explore the intricacies of this incredible program while connecting with its members on a deeper level.
There like a bake feature on the oven?
Dude, is there somewhere you need to
Yeah,
be?
I'm actually doing something. Why are you so jumpy?
To oblivion. I was trying to be good, okay? I'm trying to have breakfast ready for everyone.
My name is Alex. I'm a paramedic. I've been a paramedic for about 10 years now. I've been a flight clinician for the last 3, and I've been on the Mobile ECMO program for about a year. When I'm not flying or working at the hospital, I enjoy snowboarding. ECMO is a portable cardiopulmonary bypass system that we can use to help patients that have either sick lungs or sick hearts or both, because we can do the job of both of those organs. We can oxygenate the blood, which is the job of the lungs, and we can circulate the blood, which is the job of the heart. So for patients that have an illness or an injury to one or both of those organs, it allows us to support their body as they recover.
Big fancy term for basically saying that it takes the blood in your body, pulls it out, puts it through a membrane that allows the device to add oxygen, but also remove CO2, which is the basic function of our lung. And then the pump, it spins it and pushes it back in the body. So essentially what we're doing is we're replacing the heart and the lung of our body, being it's at a state where it can no longer function. So we take the blood out, push it through the machine, do the function of the lung, and then push the blood back in. Flow is really important for the brain. And so we have to somehow get oxygenated blood up there, and through the cardiac assist device, ECMO, it allows us to do that.
And it allows us to use this device that is able to take over the job of the heart and lungs and give the body time to rest and recover and get through whatever illness is going on with them.
Hi, I'm Kevin Rixman, currently a flight nurse and paramedic, and then the clinical supervisor for the Mobile ECMO program. Been flying for about 7.5 years and been the clinical supervisor for just shy of 5 years. In my spare time, I enjoy being out on the water on the boat and sitting around a campfire.
As a mobile ECMO clinician, Kevin has a lot of responsibilities. Not only is he assisting the doctor during the procedure and managing things like airway and resuscitation, but he also has to make sure that all of his equipment is stocked and functional.
These are cannulas. So that's what might be doing all the right sides. All of our clinicians wear our own flag. We had a founder who thought of bringing patients back to the cath lab while in active cardiac arrest and doing PCI on these patients, thinking ideology was that there was an underlying lesion. Instead of fighting the Lucas or a mechanical CPR device, Dr. Yiannopoulos thought, let's just put them on ECMO and then I'll go in and fix the lesion. And after attempting that on several patients, found to have really good outcomes. And this is where the birth of our program really started in 2015, where Dr. Bardis and Dr. Yiannopoulos really leveraged and moved forth to where we are now.
Hello, I'm Jason Bardis. I'm the Associate Program Director for the Center for Resuscitation Medicine at the University of Minnesota. I'm an interventional cardiologist and critical care cardiologist also at the University of Minnesota, and the Medical Director of our cardiac ICU. In 2014, we were looking at the data from the state of Minnesota's cardiac arrest patient population. And what we saw was that if you were lucky enough to be admitted to the hospital, you did pretty well. But only about half the people that could have done well were actually admitted to the hospital because that half never received any ROSC. They never achieved pulses from standard medical care in the field. And the question at that point in 2014 was, what do we do for those half of the people who never achieve those pulses and never achieve ROSC? The concept was that ECMO would provide artificial pulses. So the changes that we underwent at that point was to really fundamentally change how EMS services provided resources for cardiac arrest patients by shifting from a stay-and-play model where they provide medical care for patients in the field until an absolute outcome was understood. Either they had pulses or they didn't and they would die. And shift from that mentality and that framework, which is a national framework, to one that was very new and innovative, which was mobilize those patients while CPR is ongoing to get to the hospital. And so in December 2015, we started the ECPR program at the University of Minnesota, where EMS agencies were taking those patients that didn't get pulses in their early phase of care in the field. They would continue all the care they would provide in the field in the back of an ambulance while moving and bring them to us at the University of Minnesota, where we would take them into the cath lab and put them on ECMO.
Is there a status higher than you have now?
Years ago.
I never ski with AirPods in, and I think I can.
We saw in the first year that we had a 40% survival rate in this patient population that would otherwise have been nearly 100% death. And with that, those encouraging results, we then move forward thinking about how we bring this to the rest of the population. It was a very time-dependent intervention where if we received patients to our institution, we're able to get them on ECMO within roughly 30 minutes of their cardiac arrest. Almost everyone survived. And when we looked at the time dependence of that effect, we saw that really every 10 minutes that went by, 25% more people died. And so we were really limited in the geography of this intervention. We could only bring people from so far away and get them to us in a time where we could actually help them. And the question then in 2017 or so was, how do we bring this to more people? How do we get this to the entire state? How do we get this to the entire nation? How do we take people from far away and still give them this intervention? And at that point, the only way to do that was to go mobile.
Our team is a two-person team. We have a physician provider that does the actual cannulation procedure. And then the other person is one of our clinicians. All of our clinicians are HEMS clinicians initially. We feel that background gives a really good blend of the high acuity critical care knowledge that these patients need for the resuscitation, and then also gives you a really good kind of operational and logistics backbone of working in austere conditions, in resource poor conditions, in areas where you're going to have to just make decisions.
While we definitely appreciate the assistance and the resources and the skills of the physicians and nurses and respiratory therapists at the sites where we cannulate, we want to be completely independent of those resources in our cannulation so that we provide everything we need, so we're not dependent on the experience of the person that we find at the bedside when we arrive.
My name's Alec. Originally got my paramedic over in Maine. Moved out to Minnesota after working in Colorado as a flight paramedic for a couple of years. Been a flight paramedic now for almost 5 years. Been doing the mobile ECMO for about a year. When I'm not working, I like to actually fly my own airplane. During COVID, kind of got a little bored and a little stir crazy. Ended up getting my pilot's license. Most of us had been working cardiac arrest either in emergency department or on the scene of the cardiac arrest, and either getting ROSC and going down that pathway, or termination of the cardiac arrest after 20, 30, 45 minutes or something like that. We're now asking these providers, both physicians and hospitals or EMS providers, to instead recognize a patient as a candidate within the first few minutes of their arrest, and actively, while providing compressions and ventilating the patient, extricate the patient from the house or the hospital, arrange for transport, either air medical to reach some of our further out community hospitals, or some of our EMS agencies that are further out, or placing them in their ambulance and driving these patients to one of our cannulating hospitals. And this is a lot of legwork for these EMS providers to accomplish, while still providing great high quality care that provides these patients to be candidates once they get to our facility.
So this is the actual cardiac assist device. We use Get Go or a McKay pump, and we have it as a prime circuit. And what we found is that if we have a patient that clots off the pump, we have to rapidly switch out circuits. And so instead of just switching out the circuit, we end up just exchanging the entire machine with the circuit. So we keep this connected to the CardioHub 24/7, ready to go. So this is the circuit, oxygenator, which is what does the CO2 removal and the oxygen addition. And then this is actually the pump that does the flow for the patient. So it takes the blood out of the body and pushes it back in once it's gone through the oxygenator. Secondarily, we have a hand crank in case we have a screen failure. And so we have a built-in emergency hand that can live on the pump as well. So with that, we know not every patient should go on this device. And so we have criteria that allow us to decide should we or shouldn't we. Here at our program, we find it very valuable to bring all of our cardiac arrest patients that we initially screen positive for ECMO to either a cannulation suite in the ED or to the cath lab and analyze the patient for candidacy. And what that looks like is we bring the EMS provider in with the patient ongoing CPR. We slide them over to a fluoroscopy table. So we're a fluoro-based team. We place wires in the vessel. So one in the venous, one in the arterial, and off the arterial needle puncture, we analyze a blood gas. And so we're looking to make sure that there's physiological parameters for signs of life, basically. And so that is if we have a hypoxic blood gas, so PO2 less than 50, we've found that to be less favorable for outcomes than someone who has a PO2 of 60 or even greater than 50. So a second lab value that we look at is lactate as well. So we do have cutoffs. So with a PaO2 and a lactate greater than 18, we tend not to cannulate. Now, again, as I said earlier, these are all extremes. So we have cannulated patients with less PaO2. We've cannulated patients with greater lactates than 18. But in general, we do have cutoff parameters. So basically, we use an easy criteria, age 18 to 75, and these are all soft parameters. If you don't have a definitive age, you can use your best judgment call of this looks like a 75-year-old male. Once they're on pump and we realize they're 77, it's not like we disconnect the pump or anything like that. It's all rough criteria based off of appropriateness. So with the 18 to 75 years of age, we ask that there's no comorbidities known. And what that basically means is like, we don't want someone from the nursing home, someone who's in end stage cancer, end stage kidney failure, things like that. So we want the best potential for survivability. And then we ask that they're in a shockable state. So we know that there are other rhythms out there that we can potentially put on ECMO and have good survivals, but the time is of the essence for those patients. Asystole, the data suggests that less than 1% of those patients will always survive. So VFVT is the rhythm that we ask for, and we require one failed shock. And so the earlier we can recognize this patient, the faster we can activate the mobile team, and the quicker we can safely transport to an ECMO cannulating site, the better. Again, when we talk 1 minute is 2.5% survival, the faster we move.
Multiple arrhythmias are fatal if left untreated. Rhythms like asystole and pulsus electrical activity cannot be treated with electricity. Ventricular tachycardia and ventricular fibrillation, on the other hand, can often be converted to a stable rhythm using an electrical shock called defibrillation. The criteria for mobile activation is one failed shock. This means the patient presented in VFib or VTAC, and defibrillation failed to convert them into a perfusing rhythm.
Hi, I'm Professor Dimitris Yiannopoulos. I'm an interventional cardiologist here at the University of Minnesota, also the director for the Center for Resuscitation Medicine and the Minnesota Mobile Resuscitation Consortium. The Mobile Minnesota Resuscitation Consortium is a citywide and statewide, effectively, program that has been created by collaboration of multiple EMS agencies and healthcare systems. Because such a unique collaborative effort for cardiac arrest management has never been done before, our program has served as an example for other programs around the country to develop this infrastructure to provide the services for their patient population. All of this was made possible because of the generous contributions from the Helmsley Charitable Trust. And although we have a significant invested infrastructure from the grants, the major principles that guide our efforts can be replicated elsewhere with a smaller percentage of cost, because every time you start something new, the costs are higher because you know what you're doing. But as you advance and you know what is useful, what's not, the cost for operations can decrease substantially. So we have a lot of programs around the world in the country. We're reaching out to try to understand the logistics, infrastructure, and requirements for physicians and clinicians of how to respond and how to build a program like that.
So as a part of the Center for Resuscitation Medicine, which is through the University of Minnesota, we initiated the AED grant, which was funded by the Helmsley Foundation. And so what this involved was a replacement or initiation of an AED in all squad cars throughout the state of Minnesota. And the new AEDs have Wi-Fi capability. So we're able to connect, monitor, and analyze every cardiac arrest that happens in the state of Minnesota as long as that AED was initiated. A part of the project also was to provide new AEDs to those squad cars, but take old AEDs, refurbish them, and then push them out into the community. So our goal is to ultimately touch every cardiac arrest patient throughout the state, whether it's through a public AED or a squad car or first responder agencies. So you can see in our supply room here is the refurbishing process, but we to date have purchased over 700 AEDs that have been pushed out into the communities of the state. So we have our primary cannulation bag. This bag comes in with all of our calls. With ECPR patients, time is of the essence. And so what we designed with this custom bag is that everything we need to get the patient on pump is on the exterior aspect of our bag. So starting at the top, we have our sterile gloves. So we can quickly access our sterile gloves. And then in this section here, we have our iStat. So we place wires and analyze an ABG on all of our patients prior to cannulation. So we're looking for our cutoffs, which is PaO2 and our lactate. We have our ultrasound probe, contrast dye, and then in here is actually all of the important items needed for the cannulation. And then inside of this is all of the items we need for a primary cannulation. So we ask EMS to come in to bring their patient to us with their pants already cut off, the patient's pants cut off. And then we have our 2 wires. So we use Amplat Super Stiff. We found that to be the easier way to do the cannulation. Every vessel that we cannulate gets a dual stage dilation. So we have 2 dilators for each vessel. And then we cannulate with our cannulas.
Pick one view to get. You can get a right upper quadrant view, like, cool. If you can't get the other views, like,
I thought I
right, cool. So, like, you get patient. Yeah.
Like, it's just, then
Well, that's my thing.
don't like that, right?
and you see the IVC and it's like barely any variability. Sure.
Yeah.
Looking at Hen's environment, how many times do you is, and I also think especially like maybe pre-hop. Why can't I remember it? It's when you get an apical view, it's right at the top, when you get the slight arching in.
Oh, the D sign?
No, not a D sign, it's just like the slight arching in, a little click, a little like dip in on the right RV.
On an
McConnell sign.
McConnell sign.
I knew he would answer. He did this last time.
You guys don't know what I can do with that data.
What?
Yeah? That's right. I'm just measuring from the mark. There's 4 pounds of meat in here.
Those are breadcrumbs, aren't they?
Yeah.
You know what you should do first? It's too late.
What?
Should pour some milk on them, makes them nice and fluffy.
We cannulate in several different EDs, but we also have the truck. So ECMO 99, this is a beast of its own in the fact that we do not necessarily have the large team that we have in the ED. So when we operate out of ECMO 99, it tends to be a little bit stressful in the front that we have, on average in the ED or in the cath lab, we have about, 10 active people who can do this resuscitation till we're dropping down to a team of 2 and sometimes 3, depending on the involvement of the fire medic.
ECMO 99 offers a unique perspective as cases are filmed from multiple angles. This allows the team to conduct a thorough debrief after each case. Here in the lower left corner, you can see that the doctor has already gained access to the arterial vessel with a needle and ultrasound. Next, he moves to the venous side where a needle is inserted and blood is drawn for laboratory testing. Guide wires are then threaded into the patient's vascular system, allowing the introduction of dilators and catheters. Fluoroscopy is used to ensure that the wires are visibly crossing in the appropriate vessels. Dilators are then introduced to ensure proper vessel sizing before placing the catheters. All of this is achieved while mechanical CPR is still being provided by the Lucas device, as you can see in the upper right-hand corner.
Oh, I did forget. I forgot. You gotta put Parmesan in them. Get this, not me.
So what's it gonna be?
A cheesy surprise.
Oh, we need more cheese.
Yeah, I definitely need more cheese.
So what was the purpose of the milk?
It makes the meat softer. Oh, no, what does it do?
For the breadcrumbs, it puffs them up so they're not like crunchy.
I would say that loosely.
Most of them are pretty nice.
How do I know? I took a patient from him.
You and I met.
Oh.
We took a patient together. I was also there.
Why? That is true.
We are also helping. We boil her water.
Yeah. Keep it together, guys.
You have nuclear weapons sitting on your chairs.
Can we just put a bunch of butter in all of this?
Hot noodle.
Nice.
Butter's not really.
I'm just getting the top layer.
I think that for non-ECMO places, like being able to find where the location of the best place where you're going to best collapse of the left ventricle with not being over the LVO2, like, I mean, what a difference that can make, like, within itself.
Cool, like, you know, I'm intro rest and I have an anti-load, 65 or something like that. It's like, even with, I mean, that could be improper hand placement in itself. It's like, am I over the RV? Am I compressing that more than the LV? If I move my hands over and I came down a little bit with the end tidal, or they came down a little bit with the end tidal, like
there's
now
a good
we're
study
at
for that.
25 or 30. Yeah, and like Weingart on the IMCRIT had the guy on that, was at the origin of the study, and I mean, he made some really freaking valid points, and it's like,
I just want to interrupt this discussion to show you how nice the meatball came out. Alright, so we finished cooking, we're all getting our food ready, we've had some nice roundtable discussion about digital data privacy, and now I think we'll just say a quick grace.
Oh, thanks for
I said I should leave now before the snow gets worse, and you said no.
And it's even like for ECMO, we talk about like EMS will come in and they'll be like, oh, our end tidal is like 40. So if you have a normal end, and they're like, oh, it's normal. Like if you have a normal end tidal reading, and somebody who like, say the Lucas provides 1/3 of a normal cardiac output, right? Roughly. If you have a normal cardiac output of 1/3 and you're getting a normal end tidal, like you're so hypercarbic.
Yeah.
And just like change that mentality of like, end tidal provides great information, but it's also like, you gotta think through the actual like physiologic, like what's going on, like the RA, are you over the RA and just pushing the RA, and like, or are you just under
And you mean that in the presence of they truly don't have ROSC?
Truly don't have ROSC, yeah.
So similar to our bag setup, all of our stations or cannulating sites are laid out exactly the same. So we operate in a kit-wise fashion. So we have our cannulation kit, which correlates to this drawer here. So we have our heart pack. So everything we need, including the heparin to go on pump, is right here. Secondarily, we have our post-cannulation system right here, which includes our contralateral access, our distal perfusion catheter, and everything on this bottom section. What we have over on this wall is everything that we need in a backup situation. So we have second art line set up, we have extra sterile gloves, we have a repriming line, iota band, everything that we basically need in a duplicate system. Up in the front of the truck, though, we do have like our ALS, BLS style life support stuff. So we have our art line, our iGel, and then our bed tubing.
ECMO 3, go.
The code about a puzzle ECMO. Something they have lost. Yeah, told me to skip into the use. I'm about 30 minutes out right now.
Who is that?
Kevin is showing the truck to the team. He receives a call for an active cardiac arrest. The dispatcher tells him who the requesting agency is and assigns a communication channel.
Okay, copy Sec 4. I'll swap over and we'll start heading to the U. Time is the enemy in this whole entire situation. And so to try and put ourselves in the EMS provider's shoes and show where we can shave time is really important. And so when we go and do this education, we oftentimes foreshadow for an EMS provider to give them an idea of what the ideal call looks like. And so when we do this, we say, okay, so you guys are en route for a cardiac arrest. You receive a CAD update from PD saying that they provided one shock and cardiac arrest is still present. And so right then and there, this patient meets the criteria for ECPR. And so what we leverage is that EMS provider, based off that information, contacts our dispatch center and activates the mobile team. And we'll start responding to the closest ECMO cannulating site. But most importantly, what happens then at that point is we establish a tactical talk group where the mobile team, the EMS agency, and the dispatch center are all on the same talk group. And so once EMS providers arrive on scene, they can give a live update as to what they really have and the mobile team can ask if we want to pursue or continue, or if we want to change plans. But most of the time, once we've activated, we'll always continue and analyze that blood gas and then make the determination from there. So this is where then we ask for a rapid transport, so quickly package the patient. So put the Lucas on, put the patient in the ambulance and start transporting to the hospital. At that point in time, you can focus on doing the intubation, placing an IV, giving medication, but utmost important is to rapidly load and start transporting to the ECMO center.
Good afternoon, ECMO 3. Just confirming, heading to the university. Patient still has ROSC.
ROSC stands for Return of Spontaneous Circulation, which means that this patient now has a pulse. Kevin requests that the EMS crew obtain a 12-lead ECG. Additionally, he coordinates where he and the crew will intercept.
I'll talk to Dr. Yiannopoulos and see if we want to come still directly to the cath lab, but I'll advise, and please also update if patient rearrest.
While en route to the university, Kevin receives a call that a second patient is in cardiac arrest. Kevin must now decide how to divide resources. Ultimately, the patient without a pulse will be the first to receive cannulation. Kevin checks in with the second crew that are treating the active cardiac arrest.
We're going to head direct to the cath lab. The garage at the university is closed at this time. Come to the main entrance. I'll be on the sidewalk, and we'll take the side entrance all the way back to the cath lab, but I'll direct you. Just come to the main entrance, and then we'll jump on the curb and go that way.
Kevin contacts the cannulating physician.
Okay.
I'm like 1 minute out from the university.
Okay, bye.
He radios back to the first crew, ensuring their patient still has a pulse.
Just want to touch base, make sure patient still has a pulse at this time. Copy that. So we have another cardiac arrest coming in. We are going to have you guys go directly to the ED. They are aware and awaiting your arrival at the university.
Vitally stable at this point. Wait on the 12 liter.
Copy that. I'm just arriving at the university ED. I'll advise that you will be coming direct to their ED and then hopefully to the cath lab.
Kevin assists the first crew with getting the patient into the ED, where they'll be stabilized and evaluated for further treatment.
The time is so important. We've worked with our EMS partners in the area to make sure that we establish a central radio channel where they're able to ask questions for us. We're able to give information to them while they're responding still to cannulate and cut off the patient's pants. So we're able to not have to do that in an emergency room, make sure equipment's all bundled up so there can be a fast handoff, just stuff like that, even to the point of delaying patient report till after the patient's on ECMO, during that 5 minutes or 6 minute time frame that we're cannulating the patient. If they are still in active cardiac arrest, nothing much matters more than getting them on that ECMO device. It's what's going to save their life.
So once the time has passed, it's gone. So what we figured is, how can we go about and shave this extra time off? And one way was, instead of us waiting 20 minutes for an ambulance, why don't we drive 10 minutes and they drive 10 minutes and we find a hospital that's in that region and we cannulate.
The second ambulance is now arriving. Kevin will assist them directly to the cath lab.
I'm slid over to the table.
The patient is now undergoing cannulation by Dr. Yiannopoulos and is under the care of the cardiac cath team.
Looking at literature and some of the studies we've done, about 80% of our patient population had a coronary lesion event that led to the cardiac arrest. And so where ECMO really plays a role in cardiac arrest is it allows us the time to perfuse the brain. That's our most important thing we're going to do. We can find that we restore heart function very quickly in the post-resuscitation phase, but it's the cerebrum that really, really struggles. So what ECMO does is it allows us to put the patient on it. The heart and the lung can rest and recover, predominantly the heart at that aspect. But while that's happening, we can maintain and restore a normal flow that you and I, what we're used to the head. And that's what's really important to a neurological outcome.
Our program has a very short patient contact to on-pump cannulation time. Our average is about 6 minutes from patient contact to on-pump at flow, which is really, really great. I mean, again, we've talked about how reducing time in that low flow state is really important, and time is just one thing that we can't ever get back.
Yeah, I'm Mike Sinkula. I've been a flight clinician for almost 11 years now. Been a nurse for over 25. So I have both ER and ICU background, which I think is perfect as a flight clinician. I've been part of the Mobile ECMO team since 2018 when it started. So yeah, kind of breaking ground there. When I was 19 years old, my mom had a massive heart attack and she ended up dying. So that kind of took a little pause from school and everything, but it got me thinking about what do I really want to do in the medical field. So my mom was 51 years old when she ended up dying. My dad had, throughout my life, multiple heart attacks. He was one of the first 50 people in the United States to have a biventricular pacemaker placed. He ended up having end-stage prostate cancer, but died of a heart attack. He had a VFib arrest. And then both of my grandpas ended up dying before I was even born, before I even met them, of heart attacks. So I have this extremely long family history of heart disease. My sister at 48, who is 6 years older than me, had a triple bypass as well. So I kind of always joke about, if you hear that noise, it's just my heart, the ticking time bomb. So I'm trying to, when I get sobby with it and think about it, it's I don't want another 19-year-old kid to lose their 51-year-old mother to something that, had they had some of the stuff back then, maybe she would have lived longer. Maybe she would have lived to see, me to be the first person in my family to get a college education, or see me get married or meet my 2 children, things like that. So that's really at the end what motivates me to do this job. Yeah, still every day I think about her, and I think the things that get me the most are the things that I know she didn't get to see me achieve.
Some of us say we want to save lives and be so bold as to think that we're going to change the entire trajectory of someone's life. Most physicians don't see that. Even if they do help and save lives, they don't see it directly. They don't have the opportunity for that. This program, more than any other, gives you a chance to directly, immediately save somebody's life. This is a person that would have died without the resources and the skill provided by this team. And you take that person who would have otherwise died and you give them a pump to temporarily save their life and an opportunity to have the expert care provided in the hospital by our ICU team to get them through the rest. And while still many people do not survive this intervention, they do not survive their cardiac arrest in general, so many do because of the efforts of this program, and their opportunity to see those people have their life back and their family members have the life back of their loved one is just inspiring every day.
So with the program, we try and do the survivor dinner, and at the survivor dinner, we do kind of randomized seating because we want everyone to start interacting. So we integrate people who were healthcare providers and patients and randomized table. And so during this event, I was at a table and there were people there. So I started talking with them and just discussing, history of family and where they lived and things like that. And everything was aligning to a unique case that we had a year prior to that of a younger adult patient. And so I kept probing for more questions, and turns out that the patient or the person sitting directly across from me at the survivor dinners was a patient that Dr. Yiannopoulos and myself cannulated about a year ago. And so just like the rush of emotion from that was super moving, from the fact that during the cannulation we had questioned if we should be doing this. Is this going to be best for this patient? And then a year later to be able to shake his hand and interact with him at a survivor dinner was undescribable.
And there is nothing more exciting than sitting in a room full of people, many of whom you would not recognize from any of your previous experiences with them, and you have them individually raise their hands if they are a cardiac arrest survivor, one of the survivors from this program. And as you look around one by one, they raise their hand, and some of them you can sort of see that they were somebody you had seen before, and having taken care of them at the time of their arrest and throughout their entire hospital stay, you've sort of seen them recover. But then there are a bunch of people that raise their hand that you actually would never recognize, because the last time you saw them, they were very sick still in the hospital, and they've recovered fully. And they are now people, again, that you would not think anything extra about, that these people are average citizens that are living their lives with their families, with their work, with their vacations, with their kids, with their grandkids in some cases. And they are so happy to be back at that life. And you look around and suddenly most of the room is actually hands going up.
Speaking about the arrest trial a little bit, we ran it here in Minnesota at the University of Minnesota. Since these are a niche patient population, we knew we weren't going to get a lot of them, so we built a study that would allow us to effectively evaluate results as they came in with a fewer patient population. So the study was actually stopped because we showed such demonstrable increase in effectiveness in the experimental arm versus the control arm that the withholding treatment on the control arm was deemed unethical. So it was actually stopped by the IRB. It wasn't that we discontinued the study or the study was discontinued. We showed remarkable success, and so it was deemed that it would be inappropriate to not provide this standard of care to all patients that would come in.
It would be great to be able to expand this across the entire state. There is no reason that somebody's medical care and their coverage for a cardiac arrest that they may have out in rural Minnesota should be governed by where they live. There are some ideas and some plans in the works. So the first is to be able to take this cannulation to the front yard and the living room of our patients. You can't be much faster for response to a cardiac arrest than to bring these resources to the site of the cardiac arrest. Rather than having to transport that patient at all, bringing the full equipment and team and expertise to the site of the patient's cardiac arrest and cannulating them there. To mobilize that even further and faster, we need to remove ourselves from a large vehicle and be able to bring ourselves to the site. And that means miniaturizing some of the equipment that we need so that we can cannulate at the site of the cardiac arrest. Miniaturizing the ECMO pump, miniaturizing our bags and the equipment we need, and finding ways to cannulate without the aid of fluoroscopy, perhaps ultrasound, and all of that equipment. So we're already working on a path to be able to cannulate patients in the back of the standard ambulances that EMS services use now, to be able to bring the patient from their home into the back of the ambulance that would today be transporting them to a site of cannulation. Instead, that ambulance would be the platform for cannulation, and we can bring the other equipment with us to cannulate them in that site, stabilize them on scene, and then transport them, again, saving a substantial amount of time and the uncertainty and potential risk of transport. We are also working on reaching further out. So instead of having a team that drives to them, having a team that flies to them in helicopters that would be able to reach them. There are limitations to that platform as well as with any helicopter-based strategy, but we certainly will be able to reach much further. And if you imagine, instead of driving a half hour out, which is, again, our current limitation, we try to think about a half hour drive time. Flying a half hour is much further and much faster across much of the state. And so I think we will be able to reach a significant portion, well over 50, maybe closer to 75% of the population of the state of Minnesota with an intervention such as that. And if we are able to improve with that, our ability to cannulate, get people on pump even faster, then we will be able to add to that time and get people stabilized even faster. The part of this whole program that I think is under discussed, and part of any ECPR program and really any resuscitation program that we need to discuss more, is the improvement of the quality of the CPR patients are receiving. CPR has not progressed a whole lot in the last few decades. So an example would be, if we can provide a medicine that improves the blood flow provided by CPR, perhaps instead of being bound to this 30-minute drive time, we could have a 1 hour or 2 hour drive time, in which case even the ground-based strategies can be more effective across more of the state. So while we work on getting our expertise and resources to patients faster, flying out to them in the future in a helicopter to deliver those resources to the patient across the entire state of Minnesota, perhaps we can actually have innovations on the CPR side.
We still have recognized that there is a lot of room for improvement, and our goal is to have a survival rate of close to 70% in the next few years for the FRS patients and significantly high survival for PEA patients. In order to do that, we need to continuously try to figure out ways to improve the system, but also find innovative ways to deliver the life-saving therapies of ECPR as early as possible.
It'd be better to have this be full backpack.
Yeah.
2 straps, because then...
I mean, it's so heavy we can just grab it like this.
The University of Minnesota continues to press forward with developments geared toward further mobilizing and increasing the portability of ECMO. Research is constantly exploring new approaches, contributing to ongoing innovation and life-saving technology.
I'm putting it down. Put it down. Don't put it there. Put it down. Yeah, like that. Net. That's it.
Support with this? No, I didn't see your text, sorry. Okay. Yeah. What is your... Are you in the office? Oh, you're at the loading dock? Okay.
Yeah.
Hi.